In dorsal position, you'll do local examination of vulva and introitus. Then you will tell your examiner, madam, for further examination, I can't use couscous. Say, I cannot use couscous. Examiner says, why not? You tell her, Dr. Rashid told us it will be suicidal. She'll laugh. She'll laugh. Maybe when she was at your stage, I told her that as well. So, which position you like? You say one of the three. Fourth is best, but generally you use one of those. So left lateral, to inspect interior vaginal wall. When you look at the interior vaginal wall, you will see the fistula. Indication of the fistula is bladder wall or bladder epithelium is red and vaginal epithelium is pink, which you always see. So through the pink anterior vaginal wall, you will see a red epithelium. That is bladder. That is bladder. So you evaluate site of fistula and size of fistula. Site and size of fistula. Normally, vesicovaginal fistula is located in the middle of the vagina. Size could be variable, it could be very small, it could be few centimeters, large enough, or it could be the whole anterior vaginal wall is absent. What you see anteriorly is all red. That is bladder wall. So it could be, the size could be few millimeters or few centimeters. Next thing which you notice, how far the fistula is from the urethra. If it is further away, your repair is likely to succeed in making the patient continent. If it is involving part of urethra or whole of urethra, because then micturition mechanism of stopping the stream is at the neck of the bladder, at the internal urethral meatus. If that is damaged, maybe you are successful in repairing the damage, but not necessarily making the patient continent. So evaluation in that way, number one, site, number two, size is important. Whether it is involving urethra in any part or whole of it or not. Further away, good. Third factor which you will look, if fistula is large, whether it is adherent to the pelvic bones. The damage extends right up to the bones. This is to evaluate how successful you are going to be in repairing that fistula. If it is adherent to the bones, you have to mobilize large part of the bladder, then success is going to be lower. And fourth thing is, you look for any infection present in that area. So from examination point of view, We go back. After taking history, general physical examination, I told you, general physical examination, you should exhibit to the examiner that you are looking at eyes, anemia, nutrition, and things like that, visible. Just don't do this. Your examination is done as you're in the habit of doing in your practice. And then local examination. After local inspection, at the best you can do local inspection. After local inspection, describe sheet, describe pad, and smell that it is urine which is escaping. And urine has a special smell. Then tell the examiner, now I have to change the position. If she says yes, then generally the position which you have always used is left lateral. No harm, use that. If you want to be smarter, use Sims or Sims modified, whatever. I don't want to go into details of that. And if examiner asks you which is the best position to examine, then that is knee chest position. That is knee chest position. I am not suggesting that to you in the examination, because if the patient refuses that, then it kind of creates little conflict. You are asking for something. You want most cooperative patient. During history taking, tell her that is very important for you. It's your examination vital, make or break situation. So seek full cooperation from the patient. So if you put her in knee chest, generally they don't like it. So that's why that, although the being the best. This is the position which Marion Sims prescribed for VVF. For VVF. Okay. So while doing speculum examination, you look at the site, size, whether urethra is involved or not. Describe that way. All these things, describe them to the examiner. Size important, small, easy to repair, large, more difficult. If it is involving urethra, say this. Even after successful repair, patient may not be continent. Then if it is adherent to the bone, say it's too large. Only specialists should do. Amateur like me may not, because it involves stripping the bladder from the bones, bringing large gap, closing it, and then look for any infection if it is there. Because if infection is present, you should not be repairing it. Postpone repair. After you have evaluated that, then next thing is pre-op preparation. You decide if all is well, you decide we'll repair it because I can do this op. Then pre-op will be again, she is not anemic, she is not undernourished, she is not dehydrated, all this, and she doesn't have any other problems, any medical problems. If you have excluded those, you have counseled your patient, then according to the textbook, vesicovaginal fistula can be repaired abdominally, vaginally. Generally, urologists repair it abdominally. Gynecologists repair it vaginally. But it could be combined team, depending upon the size. After anesthesia and all that, repair involves Number one, mobilization of the bladder and vagina. It should be mobilized to the extent that when you close the gap, it should not be under tension. It should not, the tissues should not be stretched. They should come easily close to each other. The mobilization should be that level. Then close the bladder, generally by continuous suture. And after closure of the bladder, bring tissues outside vagina to lie between the bladder and the vagina. Interpose tissues. So they don't, the two epithelial walls of bladder and vagina, they don't lie against each other. Some tissue is in between. Generally, it is recommended, not always practically possible, that if you close the bladder, transversely repair the vagina vertically, so that the two repairs, they lie like this across. They are not in opposition with each other. Generally. But it's not the hard and fast rule. Make sure hemostasis is complete. Yes, during repair or closure of the bladder, if you can see ureteric opening, the two ureters opening, the fistula is large. Make sure you're staying away from that. You're not stitching the ureteric opening and closing it. After finished, immediately put a Foley's catheter for continuous drainage. If need be, pack vagina if hemostasis is not complete. If hemostasis is complete, then pack is not necessary. Prescribe antibiotics. And pain relief. This is almost part of your operation at the table. Then it is not post-op. This is part of the operation. Passing Foley's catheter, packing vagina to secure hemostasis. Antibiotics, all done there on the operating table. Then we come to the post-op care. Top of the list, loud and clear, you will tell your examiner, I will inspect urinary bag every hour. Generally, we put Foley's catheter, and after 12 hours, we go back to drain the bladder bag. Not for this patient. Not for this patient. Because if you go back after 12 hours, and for 12 hours, somehow the catheter was blocked, then that urine will accumulate in the bladder, stretch the bladder, and your repair will break down. Foley's catheter is put in to avoid stretch on your bladder repair. So your strict instructions on the bladder bag every hour, it must be emptied. Normally, we produce 1 ml of urine every hour. Every minute. So after 1 hour, when you go, there will be 50 to 60 there should be 50 to 60 milliliter. If it is less, it means some obstruction. So that's why it's so important. First thing, you tell your examiner, I'll put Foley's catheter and inspect bladder every hour. And obviously after that, you take care of pain, her nutrition, and continue antibiotics. Generally, it is recommended that if all is well, patient is dry, that after 3 weeks, you will remove Foley's catheter. So patient should remain with you for at least 3 weeks. If the patient is continent, go home and say your prayers for being kind to you, because the failure rate, particularly in large fistula, is very high. They need redo. Which should not be done earlier than 3 months. You can go back and redo after 3 months. Then next thing is, in addition to being incontinent, these patients, I told you earlier, they suffer from being social outcasts. They are neglected by the families. So make sure they are comfortable wherever they are. Counsel the family, counsel husband. So social rehabilitation of the patient, that too is your responsibility. Number 2, generally they suffer from amenorrhea. That amenorrhea could be due to damage to the endometrium through infection, or endocrinological upset. So you have to take care of her amenorrhea as well. First, social. Second, amenorrhea. Third, if she is going back to the husband, size of vagina. Generally, the vagina gets stenosed, small. So before she goes to her husband, make sure she is fit for coitus. If need be, enhancement of vaginal capacity. And then next, she may come back to you when she can have another baby. And how will that be delivered? That will be delivered by cesarean section, irrespective whether it was ischemic damage or instrumental damage. So you have taken care socially in relation to her amenorrhea, fertility, and coitus. But if it is so unfortunate it doesn't succeed, then redo. We are nearly finishing. I'll just jump. If you redo or second or third attempt, they don't work, In second, third attempt, maybe you can interpose various tissues if the gap is too large and try to close the gap. If you fail to close the gap, your second, third attempt also fails. Then we come to diversion of urinary tract. Then there is no alternative, because your responsibility is you have to make her dry. If your repeated efforts fail, then diversion of urinary tract. The easiest way to divert is to put both ureters into the colon, but it has got great disadvantages. Diversion into the colon, it causes ascending pyelonephritis and hyperchloremic acidosis. Eventually patient die of these two things. So the patient will be short-lived. It shortens their life. Not the best. Easiest, but not the best. Better would be to create ileal bladder, ileal loop. A segment of the ileum is separated from the main intestinal tract, and ureters are put into that. Their ileal bladder, which opens in the right iliac fossa, patient can, like a colostomy, ileostomy, patient can empty that and remain dry. Empty that at will. I think only these two will be enough. Very briefly, ureteric injury. Ureteric injury, I told you, it generally can happen while doing surgery on the lower segment of the uterus. Hysterectomy or broad ligament fibroid, or while doing myomectomy on a large fibroid, anything. First thing is, if you make a diagnosis during surgery, during your own hysterectomy, myomectomy, whatever, call urologist. He will do, number one, depending upon the injury, either he may pass only ureteric catheters, which will give time for that. If it is just the clamp, ischemia of the ureter, that period to heal that, and after 3-4 months even, the ureteric catheter can be removed. So easiest is that. If not that, end-to-end anastomosis of the injured ureter. If that is not possible, then the proximal ureter can be re-implanted into the bladder. If the distance is too much, then a flap is created from the bladder, which is known as Boiry's flap. A tunnel is made out of the bladder wall. Into that ureter can be implanted. And last of all, again, ileal loop can be created, or even colon loop can be created to connect ureter to the bladder. But all this is theory for you. It will be done by urologist or general surgeon. So for you, seek help. in the examination, speak loud and clear. If I have injured the ureter, direct trauma or ischemic trauma by clamp, I'll seek help. Examiner may ask you that what will he do? He'll say, number one, if the damage is minimal, he'll repair it and put ureteric catheter, which will be left for quite a long time, few weeks or months, and then removed. Or end-to-end anastomosis, or direct into the bladder, or enough. Examiner will say, stop, no, madam, I know more. Or Boary's flap, or ideal conduit. How many options are there? Multiple options, which means for you, for your confidence, even if you're damaged, provided you make a diagnosis, no harm done. Eventually the patient will go home hale and hearty. But if you injure the ureter, don't make the diagnosis. That is critical, because patient will develop urinary peritonitis, and then peritonitis has its own complication. Even peritonitis after appendectomy can kill the patient. So this can be very serious. So while doing hysterectomy, make sure that you have not injured ureters, ureter or ureters. If you have, never mind. Never mind. If there is a surgeon who tells you he never had a problem or complication, he is a liar. At the end, I can narrate to you, when I was professor in Multan, one of Nishtarians, she came and joined me as assistant professor. Previously, she had worked as gynecologist, district gynecologist in some town. And during operation day, having coffee, we were talking about ureteric injury. I was talking to my students. And at the end of my talk, the lady asked me, "Sir, have you injured bladder or ureter any time?" I said, "Many times. It happens." "No, it has never happened to me." I said, "You're lucky if it hasn't happened. Thank God for that. It hasn't happened. But it will happen. If you do large number, it is bound to happen." So, same evening, general surgeon from same town, who was also Nishtarian, came over to Nishtar. Nishtarians have beautiful relationship with each other, beautiful. So when he came, there was dinner in his honor. And at dinner I asked that, "You are a general surgeon in such and such town. Any ureteric injury?" In Punjabi he said, "Main te nakko nak ho gaya hai." Every day. So don't believe anyone who says never. That's a wrong statement. Even if it is true, never, it will happen. You should go into, if there's a shipwreck, you're the only survivor, and you land on an island where there's nobody there. Start your life, you have enough enemies. So, injury is your enemy. If it doesn't happen, it will happen. But at the same time, I'm telling you, if it does happen, make a diagnosis, seek help, you'll be fine. Because you have taken the right route. If you're like that pigeon who shuts his eyes when he looks at the cat, then you know what's going to happen to the pigeon. Same thing will happen to you. Thank you. Minutes. Vesicovaginal fistula used to be very common. Luckily, it's not as common as it used to be. But we still see in teaching hospitals, particularly those teaching hospitals which are located in the periphery. Because generally, vesicovaginal fistula is the major cause of vesicovaginal fistula is obstetrical. And obstetrical cause is when the labor is wrongly managed. Wrongly managed. And that wrong management could be either prolonged obstructed labor with cephalic presentation. In a case of CPD, cephalopelvic disproportion, or it could be due to some use of some instrument during second stage of labor. So the commonest cause of vesicovaginal fistula is obstetrical. Obstetrical could be due to prolonged obstructed labor in a case of cephalic presentation and CPD, cephalopelvic disproportion. There, the cause of formation of vesicovaginal fistula is ischemic damage to the neck of the bladder. With strong contraction, bladder gets compressed between symphysis pubis and fetal head. Two bones, fetal bones and maternal bones. Due to prolonged pressure, there is ischemia of the bladder which is being compressed. So in that case, it's the ischemic damage. Damage is not due to instruments. Damage is because of ischemia of that part. If there is ischemia of any part of the body over a prolonged period, then the tissues undergo necrosis. Necrosis means death of the cells. So those dead cells, when they will be moved away from the living cells, there will be a gap. And generally this gap is between bladder and vagina, and it's called vesicovaginal fistula. But sometimes it could be between bladder and cervix, or bladder and uterine cavity. Then the name will be, if it is between bladder and vagina, vesicovaginal fistula. If it is between vesicocervical fistula or vesicouterine fistula. Because fistula by definition is abnormal communication between two epithelial surfaces. Vagina is lined by epithelium, bladder is lined by transitional epithelium. So when they directly communicate with each other, that is a fistula. That is a fistula. So one cause is ischemic damage to the bladder when it is compressed in a case of prolonged labor between fetal head and symphysis pubis. So the history would be usual that patient went into labor, usually prima gravida, and a young girl, a teenager, because their bones are not fully grown. So the pelvis is not fully capacitated to that level that it can accommodate the. So with prima gravida, prolonged labor for 3-4 days at home, then eventually delivered. And mind you, when she delivers, the necrotic tissue is still there. So that fistula is not formed immediately at birth. But within 3-4 days, the dead tissue is removed. So patient complains of incontinence 3-4 days after the delivery, not immediately at birth. This is important. The second type of fistula, instrumental fistula, not I would say type, second cause of fistula is instrumental delivery. Difficult delivery, maybe during your training, early years of your training, or as undergraduates, you might have seen in the labor room difficult forceps, difficult destruction of the baby and then delivery, all those difficult procedures. They cause direct injury through the vagina or cervix into the bladder, and it is unnoticed. It is not realized that that instrument, sharp instrument, made that injury. So because it is not noticed, it is not repaired. So that track of the injury remains unrepaired. When the baby delivers, immediately the urine starts dribbling through that track. So in examination, you have to inquire from the patient who complains of fistula formation or dribbling of urine since last childbirth, whether she had prolonged labor or instrumental delivery, and whether she started dribbling urine immediately after birth of the baby, or first 3-4 days she was all right, then she started dribbling. It immediately gives you an indication how the fistula was formed. Other than obstetrical cause, fistula could be due to gynecological factors. The most common, again, cause of gynecological cause of fistula formation is injury during gynecological surgery. While doing a hysterectomy or removing a fibroid in the lower segment of the uterus, but this will more commonly seen in those patients where there were adhesions during the surgery. Adhesions means previous surgery, previous cesarean sections, previous myomectomy. So commonest gynecological cause is when you do hysterectomy or myomectomy in a patient who had previous surgery, especially previous cesarean sections. Then while during hysterectomy you move the bladder away from the uterus, but Bladder is adherent because of previous scar. So if it is not completely moved away, then when you remove the cervix or lower part of the uterus, you will be making a hole in the bladder. And as I said earlier, if you haven't realized that you have injured the bladder, urine will start escaping from that injury and dribbling of urine will start. During surgery, the second type of fistula formation is not with the bladder. Laterally, when you tie uterine arteries, you may catch ureter. Or if you haven't caught ureter, you may cut it. So there are two types of injuries to the ureter. One, crush injury due to the clamp. The other one is direct injury. So in that case, urine from that side of ureter will escape and from the vault will come out of the vagina. So that will be called ureterovaginal fistula. And ureterovaginal fistula is formed usually when during hysterectomy, inadvertently, unconsciously, you injure the ureter. Injury to the ureter could be direct or through the clamp which you apply. It will be very, very unfortunate if you injure ureters on both sides. Must be very casual surgeon then, or ill-trained. But it can happen theoretically. So you may injure both ureters, then the urine will come out of vagina from both sides. If there is only one ureter injury, then the healthy ureter will pass urine into the bladder, and injured ureter urine will come out through the vagina. So half of the urine patient will pass normally, half of the urine will escape as dribbling of urine. But in case you have injured both sides of the ureters, then all urine will escape. The patient will not pass any urine, which will be very rare, I would say. Normally, all urine escapes only in a case of bladder injury. There, because urine collects in the bladder, all of that will escape through the fistula. So the history will be, patient does not pass any urine in the toilet. She doesn't have desire to pass urine. All urine is escaping through the vagina. In a case of one ureteric injury, the history will be that patient passes urine in the toilet as well as she is wetting her bed. She is dribbling. So the commonest causes of fistula are obstetrical. In Pakistan, nearly 80% cases of fistula are obstetrical. But now the gynecological fistula is becoming more common gradually. As antenatal care is improving and less trained gynecologists are doing hysterectomy, so more gynecological fistulas are coming. But in a case of obstetrical fistula, either it will be due to ischemia of the bladder. An important thing, history will be young primigravida, prolonged labor, difficult delivery. There typically the patient will give you history that the first 3-4 days she was all right, she was passing urine normally. Immediately then it tells you it is ischemic fistula, cause is ischemia. The second obstetrical cause, direct injury during instrumental delivery. There the history will be present that patient had the last difficult delivery. And following delivery, immediately urine started escaping. So this is an important component of history asking when she started dribbling urine. The examiner is very particular on this issue, that you clarify with the patient whether it was ischemic fistula or a traumatic fistula due to injury. Then, if it is not obstetrical fistula, it could be gynecological, following some surgery. Usually surgery in the lower part of the uterus, hysterectomy, myomectomy, or any other procedure. Generally, these patients would have past history of surgery. Cesarean section is commonest. Because of past history of surgery, there will be adhesions which will make it difficult for you to move the bladder down, and inadvertently you may injure the bladder. If you diagnose the injury at the time of surgery, then it's not a problem. You can repair it. But if you miss the diagnosis, then fistula will form. If injury is to the bladder, it will be vesicovaginal fistula. If injury to one ureter, ureterovaginal fistula, but patient will pass half of the urine, normally half will escape. So these are basically, I'm cutting it short. I'm not going into other causes of fistula formation like malignancy, like irradiation, like infections. All those I'm omitting because Najma asked me in the examination. In the examination, you will have any of these two types. You will not have patient with advanced malignancy. You will not have a patient with past history of tuberculosis infection. So that's why I'm confining my talk to this. Then, where it comes to a fistula is formed, patient starts dribbling. If she comes to you immediately, or it happens under your care, any of these fistula formations, then first thing is to pass a catheter, Foley's catheter. If it is vesicovaginal fistula, then possibly that Foley's catheter will drain the urine and give time for the fistula to close spontaneously. So this is immediate care. Delivery took place recently or only yesterday or 3-4 days ago, and patient comes to you that she is dribbling urine. Then immediately what you do is you pass the catheter and leave that catheter for continuous drainage for 3 to 4 weeks. If you're lucky, that trauma or fistula was small, it may heal spontaneously. During this period of 3 to 4 weeks, in addition to passing catheter, improve her general health, because they are generally anemic, poor nutrition, coming from poor social background. Improve her nutrition, improve her anemia. She may be anemic, not maybe, she generally is anemic. Improve her anemia and give antibiotics so that there is no infection. And because if there is infection, then healing doesn't take place. If there is no infection, then primary healing can take place. This is first line. It will work if the fistula is small and there is no infection and it is vesicovaginal fistula. If it is ureterovaginal, it will not work. Either one ureter or both ureter, then it will not work. Then in that case, either your vesicovaginal fistula has not healed, or it was ureterovaginal fistula, then it means this primary care has failed. Or it's possible that patient never came to you for primary care. She came to you, that delivery took place few months ago or few years ago even. Then, first thing is, if she comes to you late, then no use putting Foley's catheter, no use giving antibiotics. First thing is then from history to find out the cause, and by local examination or investigation to find out the type of fistula. So if the patient comes to you late, then first thing is you will take detailed history. Since when, and it followed what? It followed vaginal delivery, hysterectomy, cesarean section, or whatever. Followed what? And then general physical examination to find out her status of nutrition, because most important message of the day, when you become doctors or specialists, you are already doctors, specialists, most important component of your approach to the patient should be empathy. You are not a good doctor if you only make it right diagnosis, right treatment, but don't care about the patient. You have to take care of the whole patient. Her social problems, her family problems, her psychological problems, or even psychiatric problems. Take care of them. You're not treating disease. You're treating a patient. Patient is whole body, whole mind. So here, I'm saying all this because such patients who develop fistula come to you late, they are social outcasts. Nobody wants to own them. First, husband turns her out. Then in-laws send her to the parents. Now your responsibility of your parents. And even parents, because such patients, they dribble all over. Wherever they sit, they soil the place with urine. So they also get fed up. Generally, they tell such a girl to stay away from main home, main house. So they get poor nutrition, poor social care, poor psychological care. So when she comes to you late, first thing is to make a diagnosis. Second, most important, to take care of the whole patient. If need be, she is thrown out of the house, admit her into the ward, keep her in the ward till she is cured. You'll be doing great service. Don't say we are overbooked, there are no beds, then they go home. No. Be sympathetic to such patients. Be helpful to such patients. So, one, make a diagnosis. Two, total care of the patient. I am putting it that high on the list of management. During that, you will take care of her anemia, her nutrition, her general health, any infection, even emotionally and psychologically, provide emotional support to her. Be sympathetic with them. And while she is taken care like that, you can investigate to make a diagnosis the type of fistula. That can be diagnosed, number one, by physical examination, local examination. That's the easiest way of making a diagnosis. Maybe up to this you might get in the examination. A fistula patient, as Najma said, examine this patient. First, general health, general physical examination, which you will make it visible to the examiner that you care, looking for anemia, looking for nutrition, hydration, everything. And asking questions in presence of the examiner. Do you get good food? Do you get meat to eat? Do you get care, which is required by such patients? Loud and clear you should ask in presence of the examiner, so that examiner comes to know that you care. This is an important component of the patient care. Then after general physical examination is the local examination. Usually when patient is lying dorsally and dorsal position, and you look at the vulva, maybe the sheet underneath will be soiled by the time you examine. It will be wet. If it is a long case of vesicovaginal fistula, then maybe because of urine, the skin around vulva will be affected by that. All of you must have seen that. So you make it, note of it, and loud and clear tell the examiner. Madam, on local examination, I can see she was wearing a pad which is wet, or the sheet underneath is wet. It means she is actually dribbling. Then next comment will be, the vulva is healthy or is excoriated or whatever due to constant touch with acidic urine. Then you will, with the left hand, you will separate the vulva, inspect the introitus. Generally, you can see the fluid coming out. If it is coming out, say so. If it is not, say that. I can't see any urine at the moment escaping from the vulva, from the introitus. Then, if you use Cusco speculum, it is suicide. You can write down Cusco's suicide. Because you're looking for fistula in the anterior vaginal wall. And when you use Cusco's, the anterior blade covers that anterior vaginal wall, so you can't see it. Wrong speculum. Have you written down Cusco's suicide? Then it means you can't do speculum examination in that dorsal position. Dorsal position you can examine only with Cusco's. So it means after inspection of the vulva, you will say, Madam, I like to change the position of this patient. Then the change position could be left lateral, Sims lateral position, or lithotomy position. Any one of these three. Here you fail generally because you are too nervous whether you should change the position of the patient or not, and you are wondering. In that nervousness you may use, because routinely we use Cusco's. The moment you pick up Cusco's, examination is finished. So you have to tell the examiner that I have inspected the vulva, I have inspected introitus. Now I would like to change the position, and name all three. Name all three to impress her. I can change the position into left lateral, which you could normally use. All of you do that. Or Sims position, which in one of my talks, I told you how to use Sims position. Or lithotomy position. Lithotomy will not be available there. The fourth position, which is the best for such patient, is knee chest position. Knee chest position. Normally we don't use that in the outpatients because patient has taken her shalwar off, her lower dress is off, and they feel more embarrassed being naked and going into what we call sajda. Knee chest is sajda position of namaz. So, but the best is that, because in that position anterior vaginal wall can be seen as a whole by Sims position. Here you will use Sims position. Sims speculum. Sims speculum. So if I summarize, after general physical examination, you will do